We turn now to item 5 on the agenda, which is item 5, which is the new congenital heart disease review. This has been an immensely complex review, and it builds upon a history, which I'm going to invite Ian to introduce the paper, but I'd also invite Bruce Keogh to talk to the paper, if I may. But Ian, I'd like you please to kick us off.
Thank you very much. You have a weight of paperwork in front of you because this is a very comprehensive review, as it needs to be, to do justice to the subject matter and to satisfy the terms of reference that this board set 2 years ago. The way in which the review has been conducted has, I think, been very inclusive, open and transparent, and rigorous. We have set out clear models for service delivery, standards and service specifications, and achieved, on the basis of the best available evidence, making clear the basis of that evidence, a broad consensus, not unanimity, but a broad consensus on these models, these standards, and these service specifications. They include a focus on networks with 3 tiers, standards for surgical caseloads and team size, eliminating occasional practice, co-location of adults and children's sites, better early diagnosis, including fetal screening, in line with the PHE committee latest advice, support and communication with patients and families to improve their experience, better information and a focus on palliative care, end-of-life care, and transitions from childhood to adulthood, as well as peer review and better arrangements for monitoring and audit. Our analysis suggests that these proposals are affordable and deliverable, including bearing in mind existing workforce constraints. We are, through discussion with providers, I think close to achieving solutions that would enable these models, standards and service specifications to be implemented across the country. That process is ongoing, and we are expecting providers to come back by the end of October with their propositions. And I want to just put on record NHS England's thanks to Chris Hopson and NHS for providers for their help in facilitating that process. We would very much like to reach a consensus approach with providers in a timely way, so that these models, standards and specifications can be implemented across the NHS from April of next year. But of course, we are continuing to prepare for the alternative option of going out to procurement, should that prove necessary. There are, I think, 3 wider implications that I would like to touch on. First of all, these are national standards, and as we develop approaches to devolving power within the health service through co-commissioning with CCGs or devolution arrangements, such as arrangements with Manchester, we have been very clear in those arrangements that we expect national standards to continue to apply, and that would, of course, be the case in relation to the standards that we are discussing today. It is still going to be a national health service, the importance of the N in the NHS. Secondly, this is one way of looking at this is as the first of the series of rolling reviews of specialist services that we have also promised, and we will need to reflect on and learn from what has been successful in this review as we initiate that programme. And then thirdly, the approach we're taking both to the discussions with providers and the networked solutions that are being developed are heralding, I think, a rather different emphasis across the NHS on promoting collaboration between different acute providers. And in this, they are part of a direction of travel, which is then reinforced by the fifth of our new care model vanguards, connecting this to the previous piece on acute care collaboration. And addressing the point that the Minister for Productivity raised recently in a speech around getting beyond hospitals as islands of autonomy. I would finally, Chair, like to commend these models, standards and specifications to the board. I believe that they will help improve patient care and help they're a further step on the way to providing resolution to issues that have been exhaustively discussed and reviewed over the last 15 years.
Thank you.
Bruce. I think there's nothing more precious to any family than their children. And to find that your child might have a problem with their heart is quite devastating. And I think children's heart services are the quintessential interface, really, between science, technology, ethics, fine clinical judgment, and frankly, in the surgical arena, absolutely supreme surgical skill. And as a consequence of that, we have in this country, I think, very good results for our endeavour in children's heart services. But in July 2001, 14 years ago, Ian Kennedy submitted a report to Parliament which showed that there had been some significant failings in this service in Bristol and some significant lessons which could be learnt for the totality of the service across England. Jim Munro, who was a very well-respected cardiac surgeon in Southampton and subsequently president of the Society for Cardiothoracic Surgeons, conducted a second review and came to the same conclusions on the part of the Department of Health. But frankly, not much happened. And in 2007, when I was president of the Society of Cardiothoracic Surgeons, I was asked by colleagues to write to the Department of Health to point out that children's heart services were fragile and that we couldn't rule out that there might be another similar set of problems somewhere. And that letter is in the public domain and well documented. As a consequence of that, the NHS Management Board felt that it was necessary to deal with some of the existing issues which had been highlighted, but more importantly, perhaps to future-proof the service for changing science, technology and clinical practice in quite a fast-moving technological area. And on top of that, it was my view that if you're going to deal with some problems, then let's set your ambition quite high and let's aim to make our children's heart services not just good, but the very best in the world. And I think that ambition is realizable. The consequence of those discussions led to a review called the Safe and Sustainable Review, which was a difficult process, which exposed many shortcomings in many institutions and the way that the services were delivered. But the very process of holding up the mirror to those services ended up in many of the issues themselves being resolved. In the end, the recommendations which came out of that review were deemed flawed as a consequence of the process, and the Secretary of State then asked NHS England to pick up the mantle and see if we could pursue the ambition to make our services the best in the world. And the end result of that was the new review, which has been conducted by Ian's team, and in particular run by John Holden, who I think deserves a huge amount of credit for the amount of work and engagement that he and his team have put in. But what was different about this review was that rather than focusing specifically on individual institutions, it focused on asking those who deliver the service, who live and breathe the service on a day-by-day basis, ranging from cardiologists, surgeons, through to patients and parents, what sort of standards should we set in order to achieve the ambitions that we want. And so this whole process has been based on standards. And those standards recognize that over the course of the last few years, there has been massive progress in prenatal diagnosis of congenital heart disease, indeed even in fetal treatments for congenital heart disease. There have been improvements in surgical and non-surgical treatments for young children, and as a consequence of that, we've seen quite a significant growth in the number of children who live much longer and grow into adult life, and therefore become adults with congenital heart disease. That has, as a consequence, led to a focus on how many of these very different services can be brought together and help to function in a more collaborative way through networks. And what is particularly encouraging, in my view, about all of this is that the standards are really pretty comprehensive and pretty extensive, and they've been built by the sorts of people that I describe who agree. There is massive consensus for over 90% of the standards, something that we should be really proud of and that we wouldn't get in many other services. There is inevitably a clutch of standards where there's still some controversy. And so I think that will come out in the wash as different organizations begin to address them and as the networks start to come together. So my conclusion in all of this is that this has been a difficult journey which has gone on, frankly, for over 15 years since the Bristol inquiry started. We need to get to a point of closure on this because it's a small specialty that at times has ripped itself apart trying to deal with some of the very difficult issues. People are tired of this, and it's our job, I think, as a good commissioning organisation to bring this to a close, to make it much easier for those who want to practice this service in an environment which makes it easy for them to do what is right and proper for their own patients. And I think we're very close to that now. And thank you for that, Ian.
Thank you, Bruce, for those very thoughtful remarks. Just for assurance purposes, to remind the board that in addition to the very extensive documentation we've got, there has been from the outset a board task and finish group. So I've chaired that. I've been joined by two non-executives, Ed and Margaret, and we've tracked the progress of this right through the last 2 years. I would echo, obviously, what Bruce has said about the work of John Holden and Mike Wilson and others in really quite an exemplary, open model of engagement with patients, clinicians and providers in a way that I don't think we'd have got to this level of consensus without that, particularly given the damage of previous reviews. So I'm very grateful to them. I do completely understand that there are still some difficult issues which I detect the providers are as keen as we are to resolve, and if we can do that by September, October, then we will be set to have the new system up and running in time for 2016, which I think is, as you've reflected, Bruce, a fundamental obligation on us if we can possibly get there. But let me bring in Tim, first of all.
Could I just, first of all, say how excellent I think the report is, but there's just one area where I just wonder whether or not the ambition could be slightly strengthened, which relates to transparency. So one of the great principles which has been particularly played out largely through Bruce's leadership over the years has been that of open publication of outcomes, particularly in relation to surgical disciplines and particularly in relation to cardiothoracic surgery. And just if I could bring the board's attention to paragraph 75, what we're saying here, I think, and I just wanted to clarify, is that we're going to that once the data is reliable, we will encourage publication of outcomes. And the word reliable just slightly worries me in the sense that I would hope that as we implement this, that patients, public, advocates will be involved in determining at what point it is appropriate for this data to be published. because for too many years, I'm afraid, we've left that responsibility to clinical colleagues, and we now know that in some cases that has not been in the patient's interest. And the situation as things stand now, as the report identifies, is one in which when there are concerns from the data about performance, those concerns are made available to the provider, but not currently provided to the commissioner and not to the patients who are being treated. So I would just hope that in the context of so much that's excellent about this report, we can be very bold and ambitious about the putting the principle of transparency properly to work for patients in this context.
Thank you, Tim. So, first of all, may I say this data has been in the public domain for a number of years.
Yep.
It's available on the NICOR website, and you can drill down to see how each unit is doing in a vast number of different procedures, and you can filter that in a number of different ways. So that's the first point. The second point is that there is also a sort of annual report, if you like, which is not as timely as it could be, because the collection of some of this data has not been as timely as it could be. And we have had very vigorous discussions with NICOR to ensure that we get to a place where much more timely data is collected and then made available. And the third thing is quite an important point. There is no doubt that when this data is exposed to parents, and we've seen this most recently around Bristol, the parents will look at it in great detail. And actually, it turns out that they have been pretty good arbiters of the accuracy of some of that data.
No.
Bruce, you rightly pointed out that part of what's going on here is to future-proof the system, and indeed to do so by setting high standards. And to link to Ian's point that, in a sense, this is a prototype of a series of rolling service reviews that will be conducted across several areas. So, in this case and in future cases, we're going to be facing a remodelling of care pathways to which many providers are at the moment some way off the mark. What are we going to do to help the providers to attain the standards, remodel the care pathways, reach the future proofing that we want here? Because I think our approach to that, not only crucial here, but will be crucial as a role model for how we're going to help providers generally as each service review comes forward, how we help them reach a high bar which is set.
So I'll start and I'm sure Ian will flesh in some detail. So this is a relatively small area of clinical endeavour, although it's a very important one in the grand scheme of things. The number of units, the number of surgeons, the number of cardiologists, all pretty small. But one of the things that we've tried to do in this current review is to get all the providers, now that includes managerial colleagues, clinical colleagues, but providers in the broadest sense, into a room to identify what they think the problems are, and among themselves to try and find solutions. So I think we have a major facilitatory role in this particular area.
Just to add, I hope that the design of the model set out in this review facilitates ongoing adaptation and improvement. So the way in which networks are established, the way in which the networks work with each other, the way in which information is shared, that peer review occurs, and there is mutual assistance and support, will, we think, goes some way within what is, as Bruce says, a relatively small specialty towards helping with that. Supported, of course, by the myriad professional organisations, so obviously not just NHS England and the support within Bruce's medical directorate, but actually professional bodies that are already providing very significant support across the service. So I think we can be reasonably confident in this particular area, Noel, that we have a good answer to that question, perhaps a better answer to that question than some other specialties.
You talk about April 16th, which I think is right to talk about April 16, and you talk about the trajectory from here to get there, and there are twin routes. There's achieving consensus, and then there's the contracting route. Have we identified the resources, the timetable, the processes that are necessary to do the contracting route now and start that process now, as opposed to start it later? Because you don't get too much of an elapsed time if you don't start that process. So I just
Barbara in. So the review has been developed so originally under Bill McCarthy, and then my directorate have continued that work, and we've been working increasingly closely with our specialised commissioning colleagues within commissioning operations under Barbara, so Richard Jevons and his team, on developing the commissioning model that is set out in this documentation. And Richard and his team have been developing that approach, and there will be there's a long handshake between the work of my directorate in terms of developing the standards, and then that work migrating across to commissioning operations to then execute and implement. And I think we're very optimistic that the way the governance is working, overseen by the Task and Finish group that Malcolm has chaired, will ensure that that is seamless, and that the preparatory work that Richard and team have been doing is happening in a timely way to enable us to go to a procurement option should that be necessary. But I don't know, Barbara, if you want to add to my comments.
Yes, I think there's a lot of work underway to prepare, because we now get onto the hard bit, which is implementing this. I mean, it's been a comprehensive review and very difficult, but actually they're putting the final touches to this, and hopefully having the services in place that we want still requires a lot of work. The bulk of the team is coming over to commissioning operations, so it's not as if we've got a sudden loss of that team with expertise. The regional directors of specialised commissioning across the four of our regions will take the lead in implementing this, both individually where there are issues on their patch and collectively where they need to act together. We've got a group who is meeting already and who will be looking at deadlines, who will be looking at submissions with a deadline of October the 9th. And I think we're all really optimistic that the submissions that come in on October the 9th will mean that major procurement isn't necessary. But notwithstanding that, they are absolutely and entirely aware that they actually have to be doing that in parallel, so that if after October the 9th there are places in the country where it is necessary to do some sort of procurement, because again there are different models for that. So what we're doing is working up the possibilities and the models and the way we would procure it, should that happen after October the 9th. I think, as with everything we do in NHS, if the board is saying, would it be better if we had more resource on this because it is a massive task, then I'm not going to sit here and say, no, it's absolutely fine, we've got more than enough people to do this. But given the enormity and the breadth of our agenda, then I think we have a reasonable resource at this task. We will monitor it closely, and if we think there is an issue, that's a problem. I think in NHS England we have become more adept and more experienced at procurement across a range of issues that we've done recently, and we in Ops will certainly be seeking assistance and support, particularly from Karen Tackle and Paul and his directorate, to bring that procurement experience alongside us.
Thanks. I think I'm going to take that as a yes then.
I think the critical thing is, are we geared up in all contingencies to be able to implement this for April next year? I mean, I really take the final point that Bruce said. Everybody wants certainty. Everybody wants to pin this down and to get on to life, creating the highest quality congenital heart disease services in the world. John?
Can I just ask one obvious issue we can't resolve by next year is the issue of co-location, which obviously affects my hospital as well as other hospitals in the country. Have we got a feel for a timescale that we would expect that issue to be addressed, or are we open to suggestions there?
Well, if I may come in on that, I think there has been a perception that co-location and the co-location standards here imply a major reconfiguration of individual units. And the purpose of the work of the provider group has been to explore what different network solutions across different units might be possible in order to develop the service that meets the standards. And it is those conversations that are happening at the moment, and where we will get the responses back in October, as Barbara has alluded. So I think the extent to which it is or isn't necessary to consider major reconfiguration will depend on the provider response.
Okay. I think the critical thing for the board, and I'm going to invite the board in a moment to formally agree the questions that are set out on the front of the paper. Critical thing, I think, is for us to be clear that we're aiming for a set of national standards and specifications. We do not want extensive derogations from those, because that undermines the point of having done all of this work in the first place. But thirdly, that we are anxious in our discussions with the providers, and very grateful to Chris Hobson for agreeing to take on this task to help us, to find through networks or through other means ways of meeting the specifications and standards in perhaps novel and innovative methods that we haven't been able to advance before, partly because of the institutional tensions that some of these reviews have invoked. But please, if we start from the proposition that it's our intention to work closely with the providers to solve the problem, and I know that the interest in solving the problem is widely shared across the provider side as well, then it's on that basis that I would invite the board to approve the following. First, to agree the proposed model of care and standards and service specifications. Thank you. To agree the proposals for earlier diagnosis and improvements in information, which we've not touched on, but which are covered extensively in the paper. We've noted the analysis of the required service capacity, but I'm asking you now to agree the proposals for commissioning the service implementation, including monitoring and management of adherence to the standards. The board has agreed. Right. Thank you very much.